Welcome to Past Medical Histories, our series of conversations designed to inspire trainees. Through this project, we get to hear about landmark events in the history of our specialty from the perspectives of leaders in our field. And today, I'm delighted to be joined by Dr. Edward Rowland, who's a consultant cardiologist at St Bartholomew's Hospital. Now, Dr. Rowland was one of the first cardiologists to be appointed in the UK with a subspecialty interest in electrophysiology. And so his perspective is the perfect vantage point to see how the landscape of devices in arrhythmia management has changed over time. Dr. Rowland has also been a mentor and a teacher to many of the consultants who are now practicing all over the country. Whilst doing that, he's also remained at the forefront of clinical practice. So I'm delighted you've been able to make time to speak with me today.
Thanks, Nicole. It's an absolute delight to be here, and thank you very much for asking me.
In preparation for this interview, I've spoken to some of your colleagues to ask about the olden days, or the days when you were training in early days, to find out a bit about it. And they told me to ask you about your days at the Hammersmith Hospital with Dennis Crickler and Paul Curry.
Yes, indeed. Dennis Crickler was somebody who was appointed at the Hammersmith Hospital. Dennis had an interest in arrhythmias. He was what I call an armchair electrophysiologist, because actually he didn't do any of the procedures that are so common nowadays, but he was a great thinker about the science of arrhythmias, and really interested in the history and the way in which electrophysiology in the 60s, 70s and 80s had developed from electrocardiography, and the brilliant people who worked on ECGs, a lot of them from the Viennese school, and then who moved to the United States during the 30s with all the political upheavals then. So Dennis was always very interested in history and taught me a lot about ECGs. And Paul Curry was somebody who had preceded me at Bart's, he was a medical student, and then when a job came up at the Hammersmith, an opportunity to work with Paul, and we used to have such fantastic, the evenings we would spend looking at these reams and reams of paper was a huge education for me. Wonderful opportunity to get into the nitty-gritty of a world that was expanding at a hell of a rate, and I'm so lucky to have been part of that. My career has gone from not doing very much other than giving a couple of tablets of digoxin to somebody with an arrhythmia to the world we have nowadays. What a huge privilege that's been.
So electrocardiography is a term that we just don't even think about today in cardiology. And you discussed looking through reams of recordings. What was that like, and what sort of circumstances were you doing that in?
Well, this came out of the observations, the French and the Dutch, absolute god of arrhythmia work was Dirk Durer, who really started the whole business of invasive electrophysiology. So the ability to record from inside the heart and track where the normal rhythm came from. What was the electrical sequence of the normal rhythm inside the heart, and then take it back to the surface ECG. We were, I suppose, just trying to understand what all these signals meant. And
did you think there was an unmet need here? Were you aware of the conditions that you weren't able to treat?
That's a good question. I think we became very aware that there was a demand out there. The problem, I think, that I was certainly aware of is that we would spend hours studying mechanisms of rhythm abnormalities. A lot of young people, for instance, one of the things that I think helped to show was that there were a lot of young people who had intermittent symptoms, were told that they were anxious, that they were having panic attacks. And of course, we were able to demonstrate that they had inducible supraventricular tachycardias. That was a lesson, certainly for me, that you start looking and feeding back from patients the history and understanding the symptoms of the patient, and working out how the symptoms of the patient told you something about the actual mechanism. a nice example of that. I had a young chap who was, I think he was a lorry driver. Anyway, he had a circus movement tachycardia, and we worked out that it was AV nodal re-entry. And you could work out how to start and stop. We also demonstrated that actually in him, that if you increased his adrenaline levels, it would actually, in some cases, stop the tachycardia. And this was because the faster you drove it, there was a critical part of the circuit that would only take impulses up to, say, 210 beats a minute. Now, his tachycardia was normally about 180, 190. But he told me what he used to do is if he had this and he was driving his lorry, he'd play chicken with his lorry, get himself really frightened. That would make the tachycardia go faster and it would stop. And I remember him telling me, I thought, Jesus. And anyway, that was for me, a wonderful education in being able to talk to patients, understanding patients, what they were describing. And I would also say that it was a wonderful opportunity for a number of disciplines, because in those very early days when I started, it had just been the start of surgical treatment for patients with supraventricular tachycardia. And Will Seeley in the States, as well as this work that had been done with Dirk Durer and the surgeons in Amsterdam, they demonstrated that there was such a thing as an accessory pathway. It physically existed, which we knew, but you could map it. And some of the work that Dirk Durer did in the 60s on mapping excitation in the heart was just unbelievably brilliant work. And so we started working with surgeons, and that was some of the work that I did at the Hammersmith on surgical ablation and showing that freezing was potentially a good or if better technique than actually a surgeon's knife. So I'd go to theatre and spend hours with the surgeon in theatre, mapping and trying to get tachycardia started. And yes, there was some great successes, people who had out of hospital cardiac arrest due to rapidly conducted AF in the WPW syndrome, and people you could save their lives. And obviously the great consequence of being able to do that was that you had young people whose lives would be blighted, if not, unfortunately, in the rare instances, fatal. You could cure them, and the rest of their lives could be normal, almost. So it was a great education at talking to patients, working with others, and being able to spend hours and hours looking at traces and learning new things, and going around the world, quite frankly. That was, to me, I guess it was sort of made you feel part of an international efforts to improve the lives of patients with rhythm abnormalities. In the early days of ablation, so we'd worked with surgeons to understand how you could interrupt accessory pathways and a whole variety of different arrhythmias, because we operated on people with ventricular tachycardias. But it was tough going for the patients with supraventricular tachycardia, because not all of them, most of them did not have life-threatening situations. And many of them would say, well, I'm not that ill to require open heart surgery, and the risk and the time it took to recover. And VT surgery had a significant mortality and was complicated because you needed in the early days to be able to induce the arrhythmia in theatre, and that was often difficult because the patients, hemodynamically, they were often patients who had very poor function. So hemodynamically it was difficult. If you put them on bypass and then tried to map them, often the tachycardia wasn't inducible. So the whole surgical program, which was a wonderful training, and I have to say one of the things where I benefited so much was because I worked with surgeons to understand surgical technique, and that's something, as you know, I'm passionate about, ensuring that cardiologists know about surgical technique, because for many who implant devices, it is a surgical procedure, and we need to have made sure that we do it as well as any surgeon could do it. So it was a great experience. One of the first jobs I had just after my pre-registration was working for 6 months in cardiac surgery. It was at the end of Oz Tubbs' career, so he'd just retired, I think, just as I'd started my SHO job. And that 6 months was just the most brilliant training, certainly for a cardiologist, but I would argue for any physician, to be able to look after, because those days we went to theatre and stood there holding a retractor for many hours. I think 14 hours was the longest, and I remember having pitting edema of my ankles afterwards. I hadn't learned that you need to wear support stockings at that stage. And then you would then you'd be on overnight to look after the patients on intensive care unit with great, wonderful people. Some of the anaesthetists at Bart's when I did the job, and it was Gareth Rees's first consultant appointment at Bart's. Just wonderful experience where you were responsible for those patients, and woe betided if you didn't know everything and didn't know what was happening to the patient or minute by minute, if not second by second. And that was a wonderful training. So for me, that was a very important interaction, the multidisciplinarity of cardiology. And we got into, as you may, I'm sure you know about the early history of ablation. It was with this appalling business of connecting a catheter to a defibrillator and transmitting a very large voltage, 2,000 to 3,000 volts down this thing, to destroy, which was known that you could destroy the electrical conductivity of cells by delivering a high voltage. And one of the interesting things, as you know, Nikhil, at the moment, is that whole business of electroporation, which is part of what DC ablation did, is coming back in. Anyway, that was an interesting, and once you did this to deliver what was an explosion inside the heart, you knew it was the wrong thing to do. And so I think I did 3 cases, and I said, I'm not doing this anymore. It was a profound experience, because you realized that you were doing something that could easily have killed a patient, resulted in the death of a patient. And that was it was a seminal moment. There are probably 2 moments that I look back on in my days, particularly at the heart hospital, that still have an impact upon me. One was this young girl where I'd caused an explosion and she almost died. And the other was a young boy, 12, and he came, can't remember where he was referred from, and he had a cardiomyopathy and he had incessant ventricular arrhythmias, and I tried hours after hours after hours to get things right, and I couldn't do it, and he died. And it was something that still affects me even nowadays. I still look back and say I couldn't save that young boy. He was such a lovely boy, young 12-year-old, and I still look back and think, I've completely failed. And wanting to not fail again, or not harm again, I suppose is something that's just been driven me.
And how do you get past that and get on with the next case?
Probably as much as anything, having a team around you to talk with, talk through, and knowing. I think this is where perhaps the internationality of things is important. If you if you're talking and meeting people and you can discuss cases and say, look at this, I've got this case and I did this, and knowing that you compare yourself to the best in the world, and you can only do that by, in my view, by going to presenting, going to meetings, talking with people, yes, reading the literature, but you get a slightly more personal aspect from meeting people and going through other people who are doing the same sort of thing as you, and finding out that you're all in having these difficult situations and sharing those experiences. I think that's probably one of the ways that you get through it. Knowing that it will have a positive effect on you as an individual to push to improve things, to learn from it, either not to make the mistake again or to improve things, to find a new way, and knowing that you're doing the best you possibly can. We did have a young girl, I was a patient of Jane Somerville's, 18-year-old. She was a very good tennis player, life blighted by SVTs occurring almost all the time. And this was the very early days when it was recognised that you could ablate an accessory pathway. So the early work had been done on ablating the AV node, creating complete heart block. And it worked. The collateral damage was, I think, to an extent ignored, unfortunately, but it did carry on for a short while. So anyway, we knew that if you titrated the energy to a much lower level than the full output of a defibrillator, you could cause essentially electroporation, but the safety margin was absolutely tiny. And if you went up a little bit more, because you got a partial effect and went up a little bit more, it would start to cause an explosion, and quite quickly it could cause a significant explosion. Anyway, this young girl, 18, had an accessory pathway in the mouth of the coronary sinus, and we located it and delivered energy, and it had an effect, so we knew we were in the right place. And then it's still come back, so we need to go a bit higher. And unfortunately, the next one caused an explosion, and it caused a rupture in the coronary sinus. Not an enjoyable situation, I can tell you, and it's still that I remember vividly. So rapid tamponade, and fortunately, this was the heart hospital. We were in the basement, and Magdi Yaqub was operating on the top floor, which is where the theatres were at the heart hospital. And fortunately, he was between operations. So it was, 11, 12 o'clock, something like that. And he rushed down, and within literally 2 minutes, he'd opened the chest and put his finger over the hole. And the young lady survived to have a proper surgical ablation with a wonderful and brilliant surgeon who came across from the States to work with us there, called Jimmy Cox, who, as you know, is the sort of father of AF surgery. And that was, to me, that was such a seminal part, because it said to me, you must never ever do that again, firstly. And secondly, you've got a technique which, a physical principle which will work. How do you make it safe? And we were lucky enough to have, I worked with a wonderful cardiologist called Tony Rickards at the Heart Hospital, and we were very lucky that I managed to persuade another brilliant physicist called David Cunningham to come down from Glasgow. And so we had this group of people at the Heart Hospital, and we had these wonderful meetings late into the evening discussing, how can we sort this out? And it was the I come back to the sort of the teams working together with different perspectives. Tony was just brilliant at the pacing and the physiology of the heart, and did some wonderful work on systolic function, dysfunction. and as well as Tony was a sort of Renaissance man of cardiology because he was a brilliant interventionist. He essentially devised one of the very first rate-responsive pacemakers. He was a complete whiz at computing and set up the first national data set of pacing, and that was the beginning of the data for pacing in this country, which was really one of the first in the world. And David Cunningham, who came at it with the physics. So we designed, why is this thing causing an explosion? And we managed to persuade GE to lend us a camera that was being used by NASA, I think, and it took 50,000 frames a second, and we filmed what the physical occurrence of what happens if you deliver a high voltage, and worked out that the design of an electrode inside the heart was completely wrong for this purpose, so we redesigned it. And in those days, you also had at the Heart Hospital a physics department down in the basement, and there were these wonderful people who had little lathes, and they would make anything you wanted almost that was in the capabilities of the equipment that they have. And sometimes that included mending Tony Rickard's car when it used to break down outside the Heart Hospital. Anyway, but wonderful chap called Dom made a little electrode. We worked out with GE what this electrode should look like to smooth out the electric field that's delivered when you deliver a DC discharge into a catheter. We designed it, gave it to Dom. He built it on a lathe down in the basement. He stuck it on the end of a catheter, which was a standard Swan-Ganz catheter, connected it with the wire down the middle. We sent it off to be sterilized, and that was used as a catheter to do an ablation in a patient who had a fascicular VT, and it sorted the problem out. No explosion, nothing. Oh, it was such exciting times to sort of remember, and that, I suppose that was what you could do. It was in many ways. There was an ethics group at the Heart Hospital then, but the kind of oversight was trivial and not right. It's certainly in today's terms, but it was that ability to see something, a problem, look at it and try and solve it, work out how you solve it, bring it to creation and deliver it, that all in the space of 2 years, that such a stimulus to wanting to do things. And I suppose it's that concentrated time that we could do then that was a great advantage for us. It was the beginning of ablation, but the downside of that kind, because RF was coming in at the same time, and the downside of what we'd done was that it required general anaesthetic. So anyway, it's an interesting part of history.
Yeah, I think the thing that you're describing is agency, where you're describing a problem and you feel that you are the person who can go in and solve it, and not just you, the team at the hospital. Why do you think that mentality was there?
I'd like to think it's in large part due to the history of seeing what happened before, being inspired by those people before and feeling you could make a difference. And it's that ability to see that, I look at these people who made a difference, who did things, and I can do that. And feeling empowered, but obviously feeling empowered within the constraints of what's around you. And we all have limits. We all have limits on our time and our ability to keep things going, and we need support. And the bigger the problem, I think, nowadays is we need to support you young people better than we do in terms of ensuring that it doesn't fall to you to do all the steps that are necessary to push the boundaries and the frontiers of research.
In your career, you've taught so many trainees who are now consultants all over the country, and I'm sure it was the same for you. How much do you think that personal relationship with mentors matters?
huge, absolutely. I mean, for me, it's been enormous to sort of to look at the people and the talents, whether it's a cardiologist like Paul Wood, whether it's people who spend, know electrocardiology inside out, know basic principles, who've got experience, holistic experience. I think that's one of the things that perhaps we'll talk a little bit about, is the sort of world of specialization, because, I'm a prime example of that. But the mentorship to me is absolutely key, and I don't believe the youngsters of nowadays are any different than I was when I was in my shorts in cardiology, learning the business. And I absolutely believe that the advantage that I had in my era, the way medicine worked then in relatively small pyramidal systems, and society was different. I'm always eternally grateful to my wife, who looked after the children and allowed me to spend hours in the hospital. She often tells a story. I'd go home from the Hammersmith at sort of 8 o'clock in the evening, help put the children to bed, and then I go back to the Hammersmith and return at sort of 2 o'clock in the morning and leave at 6 in the morning, go back there. So I could do that because society was different, and there wasn't so much to learn. There were less drugs. There was, we didn't know as much. So I remember I gave a talk at the 20th anniversary of the first radio frequency case, and Mark Josephson, who I'd known very well over the years, and Mark was a wonderful, absolutely down, you have to know everything about this, and what he didn't know about rhythm abnormalities, it wasn't worth. They wonderful man. He and Hayne Wellens were just such impressive characters. Dogged, get to what's going on here, explain this. And Mark was sort of slightly critical of people and rushing to do things, and not spending time at it. And I sort of used to say to him, Mark, things are different. They are different. There is so much more. I think you probably know 10 times more medications than I ever had to learn. There's just so much more to learn. And obviously the thing changing society, you can't work these long hours for all kinds of reasons. One is things like European Working Time Directive. So we've got to change, and I'm not sure that my generation have helped you, and that's why I want to continue trying to help and show what is possible, what I did, and did we learn anything to learn from that, and how we can help take the pressures off your generation to be able to focus on these things that push the frontiers of medicine, frontiers of cardiology.
And let's go on to that idea then of specialisation and how we do that, because you have got new areas forming within cardiology, cardio-oncology being one. And you were one of the first cardiologists with a special interest in electrophysiology to be appointed in the country. Did you see that as the direction of travel, or a positive thing, or how did that impact work?
Yeah, did I purposely? I honestly don't remember whether I saw it as the inevitability. It was what I was interested in. I found that I just liked looking at these strange traces, and just had a penchant for it, I suppose. And there were just a few of us who were doing that. And it sort of quickly became apparent to me that there were so many patients with arrhythmias out there that needed attention, that there were just too many for the whole of cardiology to be able to deal with. And I would be able to offer things and do things that others couldn't do, and I would be able to spot things that others didn't spot. And so that sort of drove me towards the specialisation and feeling I really don't want to get into doing coronary angioplasty, and obviously time has sort of confirmed that that's the way every branch of medicine, not just cardiology, has gone. And it is, without question, the way in which it's not stoppable. We aren't going to go back. And it is what has driven so many of the improvements over the last 20, 30 years. So we have to adapt to that. And obviously the downside is if you know a lot about the sinus node and don't know about the rest of the heart, you're probably going to miss a few things. And so this ability to look at the holistic, the whole patient at the same time, I think requires a number of things. It requires recognition that what you're doing is not the only thing that's important. So ask people. It has meant multidisciplinarity within the specialism of cardiology. It has needed, and obviously another level of care to make sure that you've got people that you work with, so the teams across the different subspecialties. And obviously the time it takes to do all this has meant that you've got to have teams of people, even within, if you're the only electrophysiologist in the hospital, you can't work 24 hours a day. Who's going to be looking after them? So it's the expansion of the specialism is one of the consequences, and that's obviously expensive, but that's necessary because that's the way that improvements occur. So the efficiencies, the improvements, health, ensuring that we have a healthier population as a consequence of what we do, is the economics of it. And appreciating the economics of what we do, for me, has always been so important.
And how formally did you have to make the case for a position to specialise? It all makes sense in retrospect, but was that how did you make that happen?
Well, I'm not sure that I made it particularly happen until I got to a level. One of the things that I suppose I look back on as a significant advance that I helped to contribute to was the national guidelines, national service frameworks. And I think that was a great initiative at trying to describe what's best care, and bringing the evidence both of what we do, and I'm here talking about looking for instance in London, what do we do well, what do we not do well, what are our comparators internationally, where's the best treatment in a particular area in the world, and are we as good as that? If not, why not? And I think what I like to think of is that we set out to define arrhythmia care for a population of people, what should happen. And that, for instance, one of the small things was it meant that somebody who has an arrhythmia should be seen by somebody who has a specialism in rhythm management. So that was one of the things that helped to cement what was obviously going on. And I think reality, what has happened is that it's been accepted that if you are going to be the best you possibly can, you're going to struggle to be a coronary interventionalist and an imager and an electrophysiologist and a device implanter and an ablationist and all these things. You just can't do it. So it's come to pass that is the way it's developed. But in the early days, it was looked upon, well, not just an electrophysiologist. Well, I didn't mind that, I have to say. I was very happy just being an electrophysiologist.
Great. And now I want to ask you about a couple of clinical landmark things that I have read about and want to understand it from your vantage point. So a lot of the research in atrial fibrillation quotes the Hassiger paper from 1998 as the emergence of pulmonary vein isolation and AF ablation. How was that from your perspective in real time, I guess, seeing that data come out? Was it something that there was a feeling about in the community? And what was the general consensus in the UK?
It was a terribly exciting time. Let's put it into the perspective of we had worked out patients, the mechanism of patients with supraventricular tachycardia. We were able to do something, and that was very invigorating. That was the early 90s that we were really took off and showed that patients with Wolff-Parkinson-White syndrome could be cured. I'm sure you've seen, because I keep showing this time and time again, the image is so powerful in medicine. There's this New England Journal of Medicine article where it showed a single strip of an ECG with a pre-excited complex for the first 3 beats, then the start of radio frequency, and the subsequent beats were all normal conduction, the disappearance of an accessory pathway. And that image is so powerful. A procedure that takes an hour and a half, an hour, sometimes under local anaesthetic, and as a day case, and you cure somebody. So that was cemented in what we were doing. Jimmy Cox was working on the AF surgery, and we'd started doing some cases like that. And so the time was ripe, and Michel was just this brilliant observer and putting so many ideas together that there probably is some sort of focal origin of these. What exactly is it? And the observation of his from the pulmonary veins was what I think everybody got incredibly excited about this, because we knew even in those days that atrial fibrillation was this significant problem. I didn't think we appreciated quite the size or the dimensions of the problem, but we knew that it was of huge size. The conventional teaching had been a bit of, some of them need a bit of anticoagulants, and of course valve disease dominated a lot of the sort of thinking about atrial fibrillation. So there was an appreciation that there was a issue out there. The size, as I say, is a dimension of it we didn't really understand, but the observation that we could map something that was a focus that we could, with our catheters, identify, really sort of, this is really exciting. And like so many things, when the first case I did in I think it was the beginning of 98, it was the first case in this country, like so many of these things, it was just a fantastic, exactly the same, did it, ablated it, and completely changed that young lady, and she was in the late 30s, completely changed her life. But then the next 3 or 4 years were trying to find somebody else like that, because it's still such a complicated problem that we probably are just scratching the surface of. And there's so much, so many young people, your age and doing the same thing as you. This is such an important area to understand, because we've got powerful tools that can do a lot of things, but are we targeting the right things? Are we targeting the right patients? Are we targeting the right electrical signals, and so on and so on?
We haven't spoken as much about pacing and the emergence of the new types of pacing, and I think we should discuss that briefly, even though we might not be able to give it enough time to do it justice. How has sort of the emergence of new tools in that sphere been received? Or my feeling is very much that it's been immense enthusiasm for really being able to make a significant difference. I remember the early days of defibrillators was an interesting time, because there were a lot of people who said this shouldn't be done, can't be done, and the determination of Michel Moravsky was such an inspiration to the beginning of that world, and so very quickly the benefits were seen.
again, one of the things is, sort of looking back, sorry to keep harping on about data and our ability to examine and check and verify what we are doing. So often, don't we sort of end up showing something late after it's been introduced that perhaps we should have thought about early on. Defibrillators, still a question mark in a way about their effect on long-term survival in patients with impaired function. There's a study just started to look at patients with dilated cardiomyopathy, with non-ischemic dilated cardiomyopathy, at the impact on survival. And it's perhaps disappointing to realise that that's something that my generation should have sort of tried to work out very early on. And there's always this question about whether we are driven by technology to a very large extent, the enthusiasm for technology. And that opens up a whole area about what is it that enthuses people in cardiology? Is it the practicalities of doing things, of techniques, of procedures, of doing something? And are we as rigorous about follow-up of patients as we should be? And I look back and I think perhaps we could have done a better job at really robustly following up patients.
So speaking about the next generation, for a trainee or for anyone who's watching this today, do you think it's possible for an individual to have the amount of impact that you have had in your career starting today?
I'm sure they can have a lot more impact than I have had. Absolutely. The opportunities are different, but they are still there. There are so many things we don't understand. Well, in my area of arrhythmias, so many things. The basic physiology, so much about atrial fibrillation is unclear. A very simple example. We all know that patients with paroxysmal atrial fibrillation are more likely, in the majority of cases, to have their episodes at night at rest, vagal. How does that work? You know that in an animal model, in many animal models, you stimulate the vagus nerve, you can make atrial fibrillation occur. It's one of the best models. But how does that work in humans? And really, what does it tell us about why it occurs? What does it tell us about what we could do to have an impact upon it? There's so much data. You probably got an Apple Watch. How much data on there about heart rate variability? What does that tell us about what is going on with your rhythm? And why sometimes, if you happen to have atrial fibrillation, are you more vulnerable than others? There's an immense world out there of stuff that you guys can make a difference to and do a great job of pushing forward the frontiers. It's just having the opportunities to do it. And I'm just so fortunate that the pressures on me in my training were just so much less than your generation. So to me, that's why I want to do all that I can now to sort of just help and show what is possible and hopefully inspire the next generation. And this business of leadership getting involved in the way in which healthcare is going to develop is, I think, something that doctors should think about. It's not for everybody, as I said earlier, but it's something that if you can contribute, if you can do, it doesn't have to be being medical director or clinical director, or you find your niche, whether it's on a hospital level, on a network local level, on an national level, on an international level. There are all kinds of levels that one can find things to help the system, help deliver healthcare. But I think having the opportunity to know about it, how to access it, what are the sort of things that it's helpful to know? I found out that mostly by osmosis, and I'm not very good at it. I'm the first to admit. But I would like to see more of this actually embedded in a curriculum for trainees, so that those who are interested at least get exposure to it to find out whether it suits their personality, whether it suits their interests. And I believe that it will eventually have a benefit no matter what you do. It's just a matter of whether you do it, just whether you use that information frequently or infrequently. But so that's one of the things that, as you know, we're doing at Barts, is to try and embed some sort of leadership management part of the curriculum.
Do you think it makes the doctor better?
I do. I think it's to think about these things. There's a simple financial level. I never gave a thought, really. Most of the early days, I never gave a thought to what a catheter cost. We had to reuse them because that's what we did. So to an extent, it wasn't a particularly expensive subspecialty because we could reuse catheters frequently. We would use them 20, 30, 40 times when we would use them until they almost fell to bits. That wasn't good. There was no question it wasn't a good thing to do, but it meant that I was sort of freed to a certain extent from the financial worries of what it cost. And the first time I got involved in the finance was when we moved for single use, and we worked out actually because of recycling costs, because of resterilisation costs, we actually worked out that it wasn't actually that much more expensive for single use. It in the end became a legal issue rather than a utility issue. But getting involved in the finances, just at a simple level like that, was important for me, and it's taught me that in the end, healthcare, like all businesses, it's about the money. And there's one phrase that comes back to me time and time again, and that is the best healthcare is the best value healthcare, because you make mistakes, it's very expensive. And putting a financial perspective on things is not a bad thing to do. It's actually, for me, a very positive thing to do because it reinforces best possible care for patients.
And now looking forwards, are there any ambitions left that you still have to tick off, or anything that you want to do?
I want to understand why the vagus nerve has such an impact upon atrial fibrillation is what I want to do.
Okay, great. Well, hopefully a future trainee or someone watching this will take that as a call to action and take that on as their work. But Dr. Rowland, thank you again for being so generous with your time.
An enormous pleasure, and very kind of you to ask me.